the Black Barbershop Health Outreach Program. It's no surprise, and it's well established, that African American men are dying prematurely from preventable diseases, culminating into life expectancies that of people in developing countries. That's deplorable when you think about the fact that we live in the most industrialized country in the world. How can people that helped build this country are the first ones to leave? That's the thing that bothers me. When you think about diabetes, hypertension, prostate cancer, all these things culminate to create the perfect storm that's devastating African American men, our communities, our nation as a whole. How can we have healthcare reform unless we deal with the disparity of African American men? That's why I'm here today to share with you an innovation where we go into barbershops around the country and we provide culturally competent information to African American men. We screen them for diabetes. We screen them for hypertension. And to our surprise, many men have to be taken directly to the emergency room from the barbershop, not knowing that they had undetected cardiovascular disease. Some men have never been to the doctor in their adult life. We've screened over 20,000 men in over 23 cities and 375 black-owned barbershops across the country. And you wonder how we do it. We have a very small cadre. And you know what? I'm not a researcher. Because when you research, that means that's, for me, it's an excuse not to do anything sometimes. You analyze yourself into paralysis too much. Pilot projects and demonstrations and focus groups. What do? We take the existing resources in our communities. We take our fraternities, our sororities, our churches, our volunteers, all types. We take corporate partnerships like Abbott, the Abbott Fund is here, like Novo Nordisk, like Pharma, and we take our legislative partners, like Congresswoman Maxine Waters, who brought $240,000 to our program, like Congressman Alcee Hastings in South Florida, who facilitated a very successful program, and our 50-city tour. Our goal is to screen over 20,000 men for cardiovascular disease in barbershops. So you probably say, why the barbershop? Well, the barbershop is considered the black men's country club. You can go to almost any barbershop and be able to get just about anything in a barbershop, from tennis shoes, DVD, a tie. And for most African-American men who travel that are businessmen, the first stop you want to make is the barbershop, because you can find out what's going on in the community. In fact, one of our supporters lives in Beverly Hills. And he says, I can get everything in Beverly Hills except collard greens and a haircut. So I've got to come on down to the hood and mingle. And the barbershop is interesting because it's the only place in America where you have a tremendous cross-section of socioeconomic strata of African-American men. You have the preacher, the doctor, the attorney, the rapper, maybe even the drug dealer, and whatever they're peddling. Right in there in the barbershop, everybody's standing and sitting there together. So what do? We developed a partnership with a company called Salesforce. And Salesforce is the largest data management system in the country. So I've heard some of the previous presenters talk about data collection. And I think we may be able to show a few things about my presentation. Something is popping up, I'm sure. It's probably not mine, but we collect data in everywhere we go. We collect demographic data. You know, do you eat fruits and vegetables? Do you smoke? What's your income? What's your age? We've been able to publish some of this data in some of the recent literature in the Journal of the National Medical Association and Ethnicity and Disease. So not only do we do outreach, we collect data. And I think it's very important for us as a people to collect our own data and analyze our own data. Sometimes we get studied on and somebody else is analyzing that data on us. And I think that's a problem. So with our small cadre of volunteers, our group is about 5 people, 5 core staff. But we mobilize thousands of volunteers across the country. So what do? We take previously ununited fragments in our community and we unite them all for one cause. So what do you mean by that? So we take barbershops. The barbershop has already been there. So we're not trying to make a brand new clinic. We're not trying to spend any more money. We're just trying to work what's already there. But the most important thing that we found out is that many people are unaware of the resources that are already there. They don't know that there's a free clinic right around the corner. They don't know that they can get a free screening or a free test. I'm going to see if I can load this up. Dan, go ahead and load PowerPoint up right here real quick. Okay. They don't know that. So what we do, we mine and we excavate. And we bring together those unrealized resources. We put together what's called the Real Black Book, Medical Health Resource Guide. So with men, you gotta, black men especially, you've got to be kind of cool. You just can't call anything medical guide because they're not going to read it. But you call it the Real Black Book. And the Real Black Book, so I'm real surprised at going to barbershops around the country. So the Real Black Book is a list of all the free and low-cost healthcare resources in their immediate community that they don't know about. So many of these fairly funded programs, they get the money to run the program, but they don't hire the people from the community. So the people from the community don't know how to market, and they're never going to go into a black-owned barbershop, for sure. So they're sitting right there together. So we put together a book. They're happy because we kind of do some community navigating for them and point them in the right direction of where the need really is. We've got something here. I'm going to speed through some of this and show you some video that I think they'll give you. You can keep going, Stan. Can you put that up here? Put the fit up here? Where's that sound? So to kind of get back what I was talking about, we partnered with the Alphas. We partnered with the AKAs. We partnered with the Deltas. So I would estimate, in fact, this weekend, tomorrow, in Washington, D.C. and Baltimore, we'll be in over 25 black-owned barbershops screening people for diabetes, hypertension, and providing prostate cancer information. Now, I do want to say this one thing. A lot of people talk, but when you join the black barbershop team, I mean, you got to work. We have a lot of people who come and a lot of folks who leave. At this very moment, we've got people shipping tables and chairs to Baltimore. At this very moment, people are making lunches right now for our volunteers. That's the kind of work we're talking about, not talking about what we fitting to do. Anytime someone says what I'm fitting to do, I get scared. Because that means you're not doing nothing. We fitting. I get scared when we say that. So, got 3 minutes. So I'm going to show you our 3-minute presentation that gives you a summary, but I do want to share this with you. See this slide here? You may not be able to appreciate it. The other problem is the maldistribution of healthcare resources in our community. The first little circle there are barbershops, and the crosses are free and low-cost, fairly funded healthcare resources. They're basically outside of the black community. So you say men don't go to the doctor. Of course we don't go to the doctor because many of the resources are not there for us. So you expect us to travel long distances to get the care that we do. We'd like to see our unpaid volunteers be paid community health workers. We would like to see organizations like the Black Barbershop Health Outreach Program partner with accountable care organizations and medical homes. We believe that this kind of partnership, number one, can increase compliance, medical compliance. We can decrease healthcare expenditures, and also we can implement a culturally competent way so patients can be much more engaged and improve the quality of health care in this country. Thank you very much. Go to blackbarbershop.org. And by the way, we have a program tomorrow. We need volunteers. So we here want to work. Can I get a raise of hands? Raise your hands. See, that's what I'm talking about. No. Thank you.
Thank you, Dr. Relaford. Our next presenter is Dr. Lawrence Kaplan, Chief Executive Officer for the Oral Health Impact Project. His presentation will focus on the Oral Health Impact Project, filling gaps in oral health care today, increasing diversity in the dental workforce of tomorrow. Dr. Kaplan?
How are we doing on the presentation? We'll be loaded up in a second. Good afternoon, everyone. We made it into the afternoon. Everybody still awake? All right. All right. We're going to load up a presentation, PowerPoint presentation, where we're going to talk. How many of you are aware of how pervasive the dental disease problem is in low-income children throughout the United States? All right, I'm going to give you a brief background, very brief. Some of you are up to speed, some of you are not. It is the #1 disease among children. It is primarily an economic disease. The less money you have, the less dental access you have. The primary reasons that you cannot get, look at you go, awesome, thank you. The primary reasons, can I use the mouse, please? All right, the primary reason that you cannot get access to care revolves around transportation, education, and provider availability. This example, which is the most glaring example of a complete failure of our system, is the one that most people are aware of. It was right here, right in Baltimore, Diamante Driver's case. In Diamante Driver's case, very briefly, had a bunch of teeth that were decayed. Mother was on medical assistance, went from shelter to shelter, lost her assistance, couldn't get the child in, needed care, ultimately ended up in the hospital with an infection in his brain and succumbed to the infection, died after 2 brain surgeries and $250,000 worth of dental care. Worth of brain surgery for an $80 extraction. That's the classic case that started the last, really, we've got about half dozen years of serious investment into this problem. But it is unquestionably the single greatest disease among our children. This disease is 5 times more prevalent than asthma. We have 14% of our 3rd graders in school today in pain, with disease bad enough that they're sitting in class with an abscess in pain. They just get used to it. This is the common issue that goes on, and it's not just in urban America, it's in rural America. It's anywhere you don't have access to care. And again, those primary reasons revolve around transportation, the ability to get the child to the care, the education, which is how do I access care and what should my expectations be for care, and then provider availability. Very few dentists are willing to accept medical assistance because it pays in the lowest 10th percentile of fees. So we have very few docs that will accept these children, and adult care is a whole nother issue that we won't even get into today that is more pervasive than that. So from that problem, the superintendent of the City of Philadelphia School District came to me, and because I've been handling dental care building systems for government agencies throughout the United States for now, it'll be 20 years in December. I'm not quite as old as he is, and not quite as good looking. But he asked me if we would build a program for the city to help these children because so many of them were having problems that it was affecting their ability to learn. I said to him that I could build the program, but I wouldn't build the program. I was not interested in coming into the schools, providing dental care, and fixing teeth. What I was interested in doing was coming into the city, fixing teeth, changing outcomes, changing expectations, and changing a generation of children's futures by giving them career opportunities at the same time. So what we ultimately did was design a program that was completely self-sustaining. This program is not grant funded. This program does not require money from public resources other than from the services that are provided through CHIP and medical assistance. We needed to build a program that, see, I'm good at a lot of things, but one of the things I'm really not good at is asking for money. I'm just not good at it. So I needed to build a program where I didn't have to do that. And I wanted primarily, our team wanted to build a program where if for whatever reason funding went away, the program would still continue. If we weren't there, other people could continue with this program. But we wanted the program to do more than that. We wanted to do more than just fix care. So the program had to be economically self-sustaining. The program also had to take care of repopulating the provider pool because we have an incredible shortage of providers of dental care for these children. And it had to change the perception of the children and their families of what their expectations are for their own oral health. See, right now, if you can afford it, your expectation is that your teeth are going, you want your teeth whiter, you want your teeth straighter. That's what you want. If you can't afford it, you don't even have an expectation of keeping them. I grew up expecting to have my teeth for my lifetime. Many of these children that we started to see had never been to a dentist in their life. Their perceptions were of fear. Their perceptions were that they were going to have, that if it hurt, we get it pulled. That's what we do. So we had to work on how were we going to build a continuum of program that was going to change it, a completely different vision from what had ever been done before. Now there's been a great deal of effort by our legislative community, by legislative leaders, our community leaders, the practitioners themselves, to build programming to try and support the underserved population. The issue became, though, what those programs as a first step turned into were examinations, cleanings, and sealant programs. The perception was if we did preventive care, we would solve the problem ultimately. But we weren't treating the disease, and we weren't treating the root causes of the problem. And that was the foundation for the Oral Health Impact Project, CF Charities, and the partnership with now the City of Philadelphia, the City of Camden, and the City of Baltimore. We're responsible for approximately 150,000 children. And we don't take a single dollar of grant money to build this program. It is a fully self-sustaining entity. So let's talk about how that works a little bit. Effectively, what we required was we wanted to change what the educational impact was, educational environment was initially going into the schools. So we created an oral health aspect to the K-5 curriculum, where the children were learning about oral health, oral hygiene, how to clean their teeth, what they should expect, proper nutrition, and we embedded it into the health curriculum. So we started to educate children early. Then we provided comprehensive dental care, and this is the really important aspect, comprehensive dental care. If the child we see in a school requires a root canal, they get a root canal. If they need a cap, they get a cap. If they need a filling, they get a filling. If a tooth needs to be removed, it's removed. Obviously all with parental consent, obviously with all the proper components for providing health care that are necessary. We do it in conjunction with the principals, the nurses, and the schools. The nurses in these programs are phenomenal. They are unsung heroes within these communities of healthcare. They are the primary care provider for many, many of these children, and they don't get the credit that they deserve. I have had nurses go door to door, knocking on parents to get them to sign consent forms so these children will be seen. So the care, one of the aspects of it was we needed to change what the perception for the treatment's going to be and how they perceived oral health care and what their expectations are. So what we did was the care itself had to be compassionate. It had to be culturally sensitive. It had to be comprehensive. It had to be continuously accessible. These were the precepts we worked under. We wanted to build a program where the experience to the child for care was as valuable as the quantity of the care that they received. Because that child would go back into their class and maybe be afraid the first time, but the child next to them got care, and they came back happy. So the child came back down to see us the next day brave. We're going to do a little bit more. And maybe we just clean their teeth. But the next time we get to fill a tooth. And the next time we start solving their problems. What we learned from that was as we changed the child's perspective on oral health and what their expectations were, they brought it home to their parents. The utilization within their homes went up because they said, hey, Mom, how come you don't have teeth? The dentist said they shouldn't look like this. You got it. I'll hit your time. The dentist said you shouldn't look like this. And Mom started going to the dentist. So we increased utilization. The third aspect of it was we wanted to change what the career opportunities were because I'll give you a really quick anecdote. There was a study that was done where children in a small county in Pennsylvania had horrible dental disease. And University of Pennsylvania went in and provided care to 1,800 kids. They were able to eradicate the disease. What they didn't expect was when they did a retrospective study on that 1,800 child population, a disproportionate number of those kids went into dentistry as a profession because they were exposed to it in a positive way at an early age. So what we did was we created an oral health academy with the city of Philadelphia, where it is a full-service, full high school. They apply from all over the city. It's merit-based. Children are accepted into that program. We accept 24 per year. Those children go through that program. They graduate with their high school diploma. We're working on finishing a dual enrollment, so they'll have up to 24 college credits free coming out of that program. They'll graduate with a certificate in dental assisting. So they start off with a $15, $16 an hour job straight out of high school. And then from that program, our charity that we started, CF Charities, which are it's in your folders, will pay for their college and dental school or their dental hygiene program for them to go into careers in oral health care. And then when they come out of those programs with their degrees, they have a requirement for to provide dentistry in public health for a period of time to repay that commitment. Those children, that's the continuum of care. So what we're talking about, this slide sort of lays it all out. These children are getting early education, K through 5, on oral health and oral hygiene and what they should expect. They're getting comprehensive care, K through 12. We're there every 6 months treating whatever they need. When they come back, they're healthier than the first time we saw them. And we're talking to them about careers in dentistry every single time we see them. They're applying to the academy, and our first group is going to graduate from that academy in 2013. Those children will go on from there. So what we need from you, one, we need to require that our programming we have throughout this country is comprehensive and that it is the full continuum. Opportunity is the value here. Career opportunity, real jobs. Dental hygienists make $80,000 a year. Dental assistants are making $30,000 to $50,000 a year. Dentists are making $125,000 to God knows what a year. $250,000, $500,000 a year. These are real jobs. And the reality is the African American population and the Latino population in dentistry has not increased in the 20 years that I've been tracking it. We are now up, when I graduated dental school, about 20% of my class was women. Now it's 50%. About 10% of my class was Asian Pacific Islander. Now it's about 33%. African American, Latino, 4 to 5%. Today, 4 to 5%. Why is that? Because they don't perceive it as a career opportunity. Let's do it in a positive way, and let's require that our community programs have a continuum of care because it can be done, and it can be done cost effectively. We're already doing it. Philadelphia's got it, Baltimore's got it, Camden's got it. And we're happy to help you set it up in any program in any city that you want. So let us know how we can help you, and we'll help you structure a program. Okay? Thank you very much.
Thank you, Dr. Kaplan. Our final presenter this afternoon is Mr. Jeffrey Lewis, President and CEO of Heinz Family Philanthropists. Mr. Lewis's presentation will focus on new partnerships, ensuring access to treatment for ADAP patients on waiting lists. Mr. Lewis?
Good afternoon, and thank you. I suspect that I'm the closing speaker because I'm the one who will provide a sense of reality of what exists in the marketplace today. About a year ago, the Heinz Foundation began working and looking at the disparities in the area of HIV/AIDS. And the more we probed and the more we looked, it became increasingly more apparent that there were more and more people who could not get access to needed medications. The problem in America has not changed. In fact, it's gotten worse. 14 states in the country have cut off access to free medications to HIV/AIDS individuals because their budgets don't allow them to do it. Congress has not increased the amount of money needed to make up the difference And the result is you have people who are in hospital emergency rooms, you have people who are not getting medical care, and you have people on HIV/AIDS who are dying unnecessarily, going into hospital emergency rooms prematurely, being placed in hospitals unnecessarily, and some of whom end up in long-term care facilities prematurely because they cannot get access to their needed medications. From our perspective, nothing could be more wrong. So we designed a market-based solution that wasn't rocket science, but certainly does work. The key to this is a single entry point to give every HIV/AIDS person who is on an ADAP program, the AIDS Drug Assistance Program, access to needed medications. The Heinz Foundation joined with WellVista, which is a central fill pharmacy out of South Carolina. It runs a charitable pharmacy there. And then we approached the Abbott Laboratories because they produce one HIV/AIDS medication. And Abbott came to us and said, "This great story, we're there." It was a 5-minute conversation. That's the definition of leadership in a pharmaceutical manufacturer. That's what Abbott does. They make decisions quickly, they make them concisely, and most importantly, they make decisions. We then went to Merck, had the same conversation with Merck. And Merck spent a little bit more time, and Merck came to the table very quickly. And then yesterday I was informed that Tibotec, which is a company within the Johnson & Johnson family, joined us as well. But those are only 3 companies that have joined this effort to provide free medications and a one-stop shop process through the program that Heinz and WellVista have created. It works very simply. Any individual who is HIV/A positive, who's on an ADAP program, simply goes to your ADAP coordinator and says one thing: I need medications. The ADAP coordinator fills out a single form, 1 page, not 2 pages, not 3 pages, 1 single page. They fill it out, it's faxed in or emailed in to the WellVista program, and within 24 hours, that individual has their Abbott medications, their Merck medications, and now they'll have their Tibotec medications. It's literally that simple. It's not complicated. It was not designed to be complicated. In the HIV/AIDS space and in the healthcare world, it's about simplicity, it's about easy access, and it's about solutions. The Heinz Foundation has built a reputation over the last 20 years, since I've been president, of building partnerships and building solutions. We don't write reports. We don't spend a lot of time having conversations. If we can't get something done, we simply move on, because I don't have the patience for it, nor does the people I represent either. But the idea that you cannot access needed HIV medications is appalling. But nothing is more appalling than the companies in the pharmaceutical manufacturer space who will refuse or will not join us in this effort. This is about using medications that exist today and redirecting them to make sure that every person has that access. And every company that refuses to participate is basically sending a very simple but strategic message: we just don't care. That is not the case with Abbott, that is not the case with Merck, and that is not the case with Tibotec. And we are long past the time to be nice about this. I guess that's why I'm the closing speaker, because I'm not nice. This is what we have healthcare changes for in this country. This is what Congress worked to change. This is what you use as a market-based approach to change the face of healthcare. And the fact that HIV/AIDS has no barrier. It doesn't look at gender, it doesn't look at race. It attacks the individual. And increasingly it attacks more women, and particularly more women of color who've never participated and didn't know that this was about to happen to them. This is now an increasingly middle-class problem. It is a grown problem. It will not change, it will not shrink, unless we can get the rest of the pharmaceutical manufacturers to exhibit the same kind of courage that Abbott and Merck and Tibotec have exhibited. That's why I'm here today, to ask you for your help. The second reason I'm here today is to say thank you to all those 3 companies because of their leadership in doing this. But the final reason I wanted to be here was to listen to these really brilliant people. Because when I spend time traveling across America, you get great ideas. So let me conclude with 3 what I hope are new partnerships. In the long-term care arena, the work that was talked about in terms of the Class Act is what is the crisis in this country. Long-term care is no longer a lower-income problem, a middle-class problem, an upper-income problem. It will affect every American family. And while he is worried about, absolutely correctly, about getting people long-term care insurance, I am worried about making sure that families have enough retirement income to go and have access to. Because the brilliance of what Ted Kennedy, this was a Senator Kennedy proposal, it was the brilliance of Ted Kennedy to bring the Class Act out, and it was his colleagues in Congress who made sure it got passed, is designed to be a huge help. The work that the barbershops are doing is nationally recognized. So I want to offer them a challenge today. We'll put $10,000 on the table, and here's what I want to do. While you're treating people in barbershops, I think it's great, but I want to go a step backwards. If we can identify the LA County Jail or the LA City Jail, and you can go in and find those inmates before they're released and analyze them before them and get them into a diabetic program, we'll give you $10,000 to do it because I run a nonprofit right now to do it. And when the dental care expert talked about dental care, I'm a type 2 diabetic. I understand dental care. I grew up in Detroit. I had a dentist who didn't understand the word Novocaine. So I was the guy that sat when his parents took him to a dentist, and you held on to the chair because there was no such thing as Novocaine, and I never went back. So I don't have real teeth. You know, all of mine have been, most of mine are capped or crowned or something. And I spent $10,000 a year 2 years ago, and I'm going to spend $9,000 this year because I refuse to go back after 5 years because I'm afraid. What you've done for children is ecstatic. I am just so impressed and by what you've all done. And we will talk afterwards because I know Teresa Hines will be very interested in saying, can you take that program to Pittsburgh? Because if that child in Pittsburgh who's getting ready to learn can't learn, then we've got to help them out. And I thank you for that. But finally, I really want to pay a very special tribute to Congressman Christensen because it's her leadership. And her leadership is the reason I am here. I used to be a staff director in Congress. I spent years as a staff director in Congress. I'm a Republican. And I worked for the late Senator John Hines. John Hines was killed in an airplane accident, and about a month later, I went to work for Teresa Hines. Some of you met Teresa and probably saw me in the campaign trail. I was the bald head behind her in 2003 and 2004. And I've worked for the Hines family directly for the last 20 years. But you learn that the quality of leadership is based on people whose actions, not their rhetoric. And the lovely part of being here today is to say thank you to someone who's all about action. So I conclude my remarks with a huge thank you for the opportunity to be here and a huge opportunity to say thank you personally. Thank you.
Thank you to all the panelists. We will not have a Q&A session because we need to move right into the luncheon. Thank you again, gentlemen.
How you doing, sister?
And I get a chance to say thank you to someone who has been a mentor to many of us and a great leader in the Congress and in the country. Before I do that, though, I want to also thank our last panelists for excellent presentations, but more importantly, for the work that they're doing every day. Give them another round of applause. Next single. Oh, okay. We're going to depart from our agenda because, as you can well imagine, the person I'm going to give this award to out of sequence is a very busy lady. She's busy every day, but this is a ALC week, so we're going to do this now. So our first 2010 CBC Fall Health Brain Trust Leadership Award goes to a fabulous woman who honestly needs no introduction. In fact, when you mention the Minority AIDS Initiative and HIV/AIDS funding, the need for routine HIV testing, or for housing, or for financing in our communities, when you think about one of the most persevering, effective, and respected voices around many issues that we all care about, but specifically around the HIV and AIDS epidemic, not only in Black America, but in the whole nation and really around the world, her name is always the first to be called. When you think of members of Congress who have developed, led, and championed smart, thoughtful, aggressive legislation to improve the health, wellness, and quality of life for those living with Alzheimer's and for their families, her name is also always the first called. When you think of Congress members who have, since they began their careers on Capitol Hill, have had dedication, determination, and the utter courage to provide a voice for those whose voice might otherwise have been silenced, to show us the face of those that too many had turned away from, and to speak on behalf of those Americans, even when it was not popular again, her name is the first called. In fact, this courage and dedication is what brought about the Minority AIDS Initiative, is what helped to get the Stop AIDS in Prison Act, H.R. 1429, passed the House earlier this year, and with her voice and courage and dedication will be the one that will also have us pass major Alzheimer's legislation in the not-too-distant future, I am sure. In fact, I don't think it's possible to have a conversation with anyone about the nation's lawmakers who make a difference, who really, truly make a difference in the lives of people in this country every single day, without hearing her name called. And for this reason, she not only deserves, but she's earned more than the honor than we are giving her today. Like other very prominent and popular individuals such as Rihanna, Iman, Prince, Chaka, our award recipient too can go by one name and you will know who we're talking about. And that name is Maxine. So, thank you.
Oh my God.
So, Maxine was my very first CBC chair. I learned a lot just following her around and helping her as we went through the motions of getting the Minority AIDS Initiative passed. It has been my honor and pleasure to work with her, to call her colleague and friend, and thank you for standing and helping me to honor, and helping the CBC to honor Maxine Waters today.
Wow. I have just been elevated to a new status, Maxine. I like that. Thank you so much, Donna. I am very appreciative for this recognition and this award, and it's quite unusual. A member of Congress, your colleague, who thinks enough of you to invite you to one of these sessions and to say very special things about you and to give you an award is so unusual, and I'm so grateful. And instead of me getting this award, I should be bringing Donna an award. And let me tell you why I should be giving her an award. First of all, the Congress of the United States of America was blessed to have her come to join this body for a number of reasons. She brings with her her profession as a doctor, as a medical person, which we desperately needed for the input that's so desperately needed for good public policy. Secondly, she cares so much about health and health issues, and she's been able to help formulate a response to the crises that we've been confronted with in so many areas of health. She's got so much energy. Many of us only do our workshops once a year. Do you know what she's doing all year long? Traveling all over this country, interacting with the medical profession, making sure that our issues are being talked about, are being discussed. Without Donna, there would be no real platform for the discussion on health disparities. She really did raise this to another level. I am so pleased and proud of the work that she has done. And I want to tell you, if I have any bragging rights at all, if I have any at all, the one thing that I like to brag about is this. When I was chair of the Congressional Black Caucus, I made sure Donna became the head of the Health Brain Trust. That's my bragging right. And so, Donna, I thank you so very much. I know that you could recite, as you have done, the issues that I've been involved with, whether it was AIDS or some of the other issues that you're alluding to. But the most important thing about all of this work is this. If you get interested in something and you're able to turn it over to someone who really understands it and knows about it and willing to put time in, I mean, that's really, really all you can ask for. We all get interested in a lot of things, and I consider myself sometimes a catalyst on some of these issues and getting other people involved. And so, oftentimes you get interested in something and you can't find anybody else who cares enough that they want to spend time on it. But we're so lucky and we're so fortunate. Now, she talked about AIDS and some of these other issues, and I've gotten very interested in Alzheimer's. Guess why? I'm 72 years old. And so I better be interested in Alzheimer's. And so Donna is carrying the water on so much, and I'm not going to just throw this at Donna and say, now I've got another health issue for you. I'm going to do as much as I can, and I want Donna to help identify some other people that will take some of these issues that she's carrying, and maybe the Alzheimer's issues is one of them, and see to it that they develop their expertise and continue to push on it. But thank you so much, Donna, for this recognition. I love you very much.